Our coordinators, Dr. Biju P, Dr. Ram Gopal Pillai, Dr. Simi Harris, Dr. Sajid Mohan.
Good afternoon. First of all, I congratulate and thank the organizers of Advances 2024 for inviting me for this session, and also having such a panel discussion on medico-legal aspects of obstetrics and gynecological practice. Because as you already know, I was dealing with medico-legal cases as a part of Indian Medical Association Professional Protection Scheme for the past almost 16, 17 years. And every year, the maximum number of litigations will be from the obstetrics and gynecology departments. It may be due to different reasons. One is the obstetrics and gynecologicians are more prone to litigations because there are potentially two litigants, mother and baby. In all other cases, only potentially there is only one litigant, the patient only. But here, potentially, there are two litigants. And now the delivery will be always considered as a physiological process, and any complications in that process may not be accepted by the public. So there are certain socio-cultural issues related to increased litigations in this practice. But still, there are some issues related to documentation, some issues related to the following of protocols, following of rules and regulations, all those things are also there. So an awareness on the scenarios in which you may become liable for litigation is very important. Today's panel discussion will be, with the panelists, we will be discussing certain case scenarios. Almost 6 to 8 case scenarios will be discussed as per the available time. Before that, I will be going through a short presentation on general aspects of medico-legal issues in obstetrics and gynecological practice. So, what is litigation? Litigation is actually fighting or defending a case in a court of law. It's usually meant for civil cases, but it can be extended to criminal cases as well. And if there is a patient has got a complaint, which all forums he can approach? He can approach consumer dispute redressal, that the consumer courts. Then he can directly approach the National Medical Commission or the state medical councils. He can file a case in the civil court for damages. He can approach directly to the High Court as a public interest litigation. He can complain to police or the criminal courts under Indian Penal Code, IPC. Now it is also called the Bharatiya Nyaya Samhita. And there can be complaints in the Human Rights Commission, Vanida Commission, Lok Adalat. All these forums also entertain complaints against doctors. And for prevention, you should always have a true and MC approved qualification. Your communication should always be proper. The communication to the patient and interpersonal behavior between your colleagues, everything should be perfect. There should be academic and technical upgradation. Even if you may be a busy practitioner, continuously practicing for years and years, more than 15 years, but still, if your techniques are not current, if you don't have the academic and technical upgradation, then you may not be able to justify in court. Then you should adhere to the medical ethics and laws. And always, the first allegation against you in any litigation will be that you have not shown reasonable skill and care in your practice. So, you should always show a reasonable skill and care. Reasonable skill and care means it is not the highest possible treatment which should be given, but which is a treatment should be that which is given in ordinary circumstances as a common practice. That is what is called a reasonable skill and care. And another most important area is proper documentations. And negligence. You will be, the allegation against you in any litigation will be negligence. Negligence is actually, it does not have a proper definition, but it's a faulty behavior. It has got both a subjective and objective areas, because sometimes you can measure the negligence, but in most of the cases you may not be able to measure the negligence. That is why the differentiation between the criminal and civil negligence become narrowed, and even though we have a protective mechanism against arrest by the order of the Supreme Court, but still many of the expert committees may not be differentiating between a common negligence and gross negligence, and so at many times doctors are dragged onto the criminal courts also for trivial negligence cases. And negligence can be due to acts of omission or commission. Acts of commission means carrying out treatment beyond one's skill, iatrogenic complications, injuries due to wrong techniques, medication errors, wrong site surgery, etc. All are called acts of commission. And acts of omission may be failure to examine and investigate a patient, failure to take important histories, failure to take legally valid informed consents, failure to give accepted standard of care and treatment, failure to take proper precautions before any procedure, abandoning treatment. All these come to acts of omission. And for you, if there is an allegation of negligence, to prove the negligence, there should be 3 conditions should be satisfied. One is you should have a legal duty to exercise due care. That legal duty, in any other civil disputes, there should be a contract between the 2 parties. Then only a civil dispute can arise. But in case of medical negligence, there need not be a contract. When a patient sits in front of you and you start treating that patient, it is implied that there is a contract between the 2, although there is no written contract. So always when you start treating a patient, there is a legal duty as a doctor to exercise due care. Then there should be some breach in the duty, and subsequently there should be some consequential damage to that patient. Then only negligence will arise. But that damage need not be always physical. It can be monetary, it can be mental. So, a patient I had a severe mental worry due to the treatment instituted by the doctor. That can also be a cause of negligence. I am not going into details of criminal liabilities, but any of the criminal provisions in the IPC, grievous hurt, attempt of murder, everything can be charged against the doctor also. For example, if a patient dies during your treatment, then if somebody kills another person, he will be charged with section 304, that is murder. If a person dies during treatment, that is called a criminal negligence, and you will be charged under section 304A, that is called criminal negligence. Likewise, you can be charged for grievous hurt, all those things can be charged against the doctor. So there are criminal liabilities, and previously doctors were used to be arrested by the police for allegations of criminal negligence. Any allegation comes, the politicians and the local people will go to police station, file a complaint, police will come and arrest the doctor. Then in one of the Jacob Matthew cases came a Supreme Court verdict that there should be an expert opinion regarding that particular case, and the experts should say that there was gross negligence, then only a criminal case can be proceeded against the doctor. So nowadays, whenever a criminal complaint comes to a police station, that DYSP will refer that case to the respective district medical officers. The district medical officer will form an expert panel with the concerned experts, and if the expert panel says that there is a gross negligence, then only a criminal case will be proceeded against the doctor. But still, many of the expert panels are not giving a proper opinion regarding the case. They should opine whether it's a gross negligence or ordinary negligence, but they will say that there is some negligence. Then the police will continue with a criminal case. That's the situation now happening. Now that I am not going into the details of the doctor-patient relationship, but doctor-patient relationship has also worsened for many years due to commercialization and consumerism, media and rising awareness, declining professional standards, technological advancement, and if they don't get the latest treatment, they feel that they have got an inferior treatment, and that may raise to complaint. Lack of infrastructure, especially in many of the government institutions, they have started doing a lot of cases, but with limited manpower and infrastructure. That also giving increased litigations, defensive medicine, cost of treatment. Whenever the newer technologies make the treatment costly, people think that all the amount incurred for the treatment is going to the respective doctors, and that's also worsening the doctor-patient relationship. So another area is documentation. Whenever a litigation comes, especially because the gynecological practice is generally busy, so there may be some failure in documentation of the proper operative notes, proper follow-ups, immediate post-operative care, or post-operative follow-ups in the OPD, etc. may not be properly documented. These all rise to litigations and failure of cases in various legal forum. I am not going into the documentation and such. And as such also in many of the cases, the discharge summaries also may not be clear, because everybody is fond of writing a lot of abbreviations, TOH with VFR, PHO, etc., like that only the discharge summary will contain. And whenever the case comes, there can be a lot of, because now the thing is that even the consent may not be informed consent. Informed consent is very important, because informed consent, the parts of a proper informed consent is that what is the diagnosis of the patient, condition of the patient, what treatment you are offering to the patient, what are the other alternative methods of treatment, what are the advantages of the treatment offered by you to the patient, what are the disadvantages, what will happen to the patient if this treatment is not taken up. All these components should be there in a proper consent. Then only it can be called a proper consent. Otherwise, it's called an improper consent. And there can be invalid consent also. Invalid consent means a consent not signed by the patient. Where sometimes you will call somebody, a bystander will sign a consent. That is called an invalid consent, because that patient has not given consent for that surgery. So consent is also very important. All these areas you have to follow. And whenever there is a death, you should prepare a detailed death summary and keep it in the case sheet. Otherwise, after some time, when the legal procedures came, you may not be remembering what is happening. And even when you give certificates, you should be very cautious also. And the professional protection scheme is there to help you in any case of any cases of litigations. And regarding obstetricians and gynecologists, actually most of the obstetricians and gynecologists does not know about the language, concepts, rules, strategies, legal system, everything, because they don't have to know. Usually that does not come in the curriculum, does not come in their practice, etc. So at least a thorough understanding of the malpractice litigation scenarios is important so that they can avoid them. And the usual causes, if you generalize the causes of litigations, it can be delay in diagnosis, wrong diagnosis, complications, dissatisfaction with the treatment outcome, wrong site, comorbidities, anesthesia-related complications. These are the general areas of litigation. And litigation specific to OBG in general may be sterilization failures, antenatal checkup, lack of proper antenatal checkups, fetal surveillance, birth asphyxia, complications of operative procedures, cases related to OBG ultrasound, MTP, etc. And the majority of the cases regarding OBG litigations may come in these headings, like for example, VVF following normal delivery or some other delivery, or VVF following hysterectomy. Then normal delivery leading to cardiorespiratory death or convulsions or some complications related to normal delivery. Then intrauterine death, neonatal jaundice, eclampsia, USG showing congenital anomalies at the time of birth, then whether LSCS was necessary or unnecessary, premature delivery, whether it was due to the lack of proper treatment during the antenatal period, HI of baby, hysterectomy related complications, MTP related issues. It can be MTP related complications or MTP related some other legal issues like MTP in a minor, all those issues can come. Then sterilization failure, continuance of pregnancy after D&C, all these things, infertility, the proper consent and ethical issues, foreign bodies inside after surgery like MOP, surgical instruments, etc. All these can lead to litigations in gynecological practice. And even there are instances of intestinal rupture, etc., following laparoscopic surgery. All those things have been also so rare cases. For example, in one case, for identifying ureters during a difficult hysterectomy, stent was placed in both ureters by the urologist, but the gynecologist forgot to send back the patient to remove the stent, and the stent was placed in that patient for almost 2 years, and subsequently after 2 years only it was identified. So such even such rare cases can occur in cases of obstetrics. So these are the general areas, and there can be many legal complaints with the MTP Act, PCPNDT Act, POXO Act, and the new Artificial Reproductive Techniques Act, etc. can also cause litigations against. That's regarding the general aspect of litigation in obstetrics and gynecological practice. We have with us Dr. Biju Pillai, Dr. Ram Gopal Pillai, Dr. Simi Harris, and Dr. Sajid Mohan with us today to discuss various case scenarios. The method we have discussed and plan to adopt is we'll be today discussing on some 6 to 8 case scenarios according to the time available. So I will just enumerate one case scenario, and one of the panelists will discuss about the various aspects which should have been done, what should be the ideal method, and what was the problems that occurred with the patient, etc., with that particular case, etc. So we will first have a discussion. I think Dr. Simi Harris may be discussing about the VVF following 45-year-old underwent hysterectomy, had watery discharge through vagina after that. Then VVF was identified in the third follow-up, and patient was referred to urology, and subsequently patient was treated and was cured. Then they have given a complaint that the complication occurred due to faulty surgery, and the problem was not identified in time and referred. It was identified earlier during the IP treatment itself. Then these complications would not have been erased. That was the complaint. So what is the situation after post-hysterectomy VVF? What all things will you do immediate post-operative during the OP follow-up? What all things you are looking after, and how can you avoid such a litigation in a case of hysterectomy, VVF following hysterectomy?
Respected seniors and friends, first of all, I think we should evaluate the case before you do the surgery, whether it's a complicated case or is a non-complicated case like previous cesarean, previous laparotomies, or any case of endometriosis and all. We should anticipate the thing, and we should explain very clearly, and also we should write a consent, written consent. And the other thing is that we should make them either write the thing by themselves, and if they are not able, we should read then and then write. And we should make them sign that there can be complication. But still the litigations can come. And if you find such, if you anticipate things, you can take steps to prevent that. Like putting a stent before the surgery to avoid the injuries, maybe ureteric. And if it's a bladder injury, we are suspecting bladder injuries, we can ask for a urologist help and all. And in those cases, when you do the surgery itself, we could, most of the times we could know there could be some injury. But sometimes we can anticipate the injury and you can, prolong the stay of the, like you can put the this one and see.
Can
But
in
sometimes even
all cases can you identify VVF during the immediate
No,
postoperative
no,
period?
it may not be possible. But if you anticipate, you can just put the catheter for 3 more days, and you can. Then after discharge, when you discharge the patient, also you should explain the patient there can be something problem. Okay, and most of the times this VVF, we miss that case, and when they come for the first follow-up.
In this
also,
instant case, one of the complaint of the patient was that it was identified only during the third follow-up. That is around 1.5 months after.
Yeah, we may probably.
Can it happen after 1.5 months, or was it present during initially itself? Then, if in such cases, what should be the ideal post-operative documentation you should do in such post-operative cases?
Post-operative case, when they come, we should first ask whether they have any symptoms, like any complaints. Like most of the patient, in this particular case, they may tell they have discharge. Discharge may not be telling watery discharge. They'll be telling discharge, and most of the time, the small VVF we will miss it usually. And if you really suspect her, then.
And suppose the patient is complaining at discharge, and but you are not convinced that it's a VVF or any complication related to it, then how will you document that? What will be your follow-up documentation in the OP case sheet?
If usually when this patient comes for discharge, normally there can be discharge. So you write the normal things like general examination. See, she is vitally, she is stable. And examination, per-abdominal, you can look for the wound and all. And local examination, we usually look for the vault. But if you don't suspect a VVF, we may not go for some specific test. If still she has a strong history, then only we check for the VVF. We never otherwise look for the normal test for VVF.
So, ideally, in such case, when will you identify VVF? In such case, if the patient had a VVF, whether it can be identified in the first post-operative period or it can be prolonged.
Sir, if it's a big injury, then we can diagnose. Otherwise, small injuries, necrotic injuries and all, it will take time to create the. So we.
Okay. It's a VVF.
VVF also.
Okay. So my suggestion is that it can occur, it can be identified late only, but still when the patients come for follow-up, usually what happens is when the patient come to OPD during follow-up, nothing will be documented. You will be prescribing some vitamin B complex or some symptomatic message, if they say pain, paracetamol, etc. But usually you will not document the examination findings. If a patient was comfortable, such things will not be written. So my suggestion regarding medico-legal aspect is that always the post-operative documentation should be perfect, even when they come for OP follow-up. Otherwise, you may not be able to justify cases in courts. Now, my next is to Dr. Biju Pillai. One lady had regular antenatal checkups and ultrasound scan done by the obstetrician. Baby had phocomelia at birth. USGs were done at 10, 19, 27 and 33 weeks, and all were reported as normal. And even the femoral length was also documented. So in such cases, is it possible? Because always we justify that ultrasound is an arbitrary investigations, and everything may not be visualized in an ultrasound. So sometimes you may visualize, you may not be able to visualize certain congenital anomalies, etc. But in such case, if a complaint comes, what all things will you, what is your justification, what all things can be done to defend our case?
So, documentation is the important thing. When we do ultrasound, we have to mention what all we seen, what all we are not seeing it. Regarding this absence of the limbs, we usually, if anybody can make a mistake, even the radiologist, if they does a scan also, they also misses this type of thing. Their argument in the court, mostly because this is done by an obstetrician, if it had referred to a radiologist, and radiologist would have picked up. But there are plenty of cases, plenty of litigations against radiologists also, they have missed this type of findings. So better thing is, whatever, prevention is that whatever we are seeing, which we are not seeing also, we have to mention in the ultrasound report. But here, for another one is in our practice, because we also had issues like this. So nowadays we made routine that 1 or 2 scan, we do scan, early scan, then next scan we'll send you a radiologist. Then it's like, if always 2 reports from our side also, 1 report will be there, and 1 from the...
So your suggestion is that at least the anomaly scan should be done by a radiologist and it should be documented.
It's like, sir, nowadays almost all the radiologists, radiologists or even the gynecologists, they do call back, or anomaly scan also, they do it around between 18 to 20 weeks. Then they call back after 4 weeks or 2 weeks again for a repeat scan. Because they know that we may miss something, so that we call them back. And secondly, to prevent, tomorrow litigation comes, we can say in the court as an obstetrician, we have taken a second opinion from a radiologist. But legally, in Indian PCPNDT Act, it's clearly written, anyone with the MBBS degree with 6 months ultrasound training, or a radiologist or a person with obstetrician gynecology PG can do scanning.
Yeah, they can do the scanning. There is no legal ban.
But only thing is, gross mistakes we may...
So, the general consensus is that at least the anomaly scan should be done by a second person, and that will be better for defending such cases. And another thing is that what usually happens in ultrasound reports is that not only in gynecology but in other areas also, there will be a standard template. And if there is an abnormality, that standard template will be edited and rest of the things will be written as normal. But suppose when you write limbs as normal and then you see that there was no limb, then you cannot, if you have only, you can write it as normal when you see. Otherwise, you can see not visualized. If you have not seen something during ultrasound, you can report that you have not visualized it. But if you write that it is normal, then in legal terms, it means that you have seen that and it appears normal. Then if it is absent, if that limb is absent, then automatically the corollary will that you have done a negligent scanning. So there is another issue. So don't use the standard template always. Whenever you see something, you can write that see. Otherwise, you can tell that it's not visualized. That will be the ideal thing to be in ultrasound report.
Sir, I have one small doubt, sir. When you are telling that every patient should be done one more anomaly scan,
that I don't see, but at least if the gynecologist is doing and following up the case, regularly doing ultrasound, then the anomaly scan, you can leave it to one radiologist. Or suppose if one radiologist is doing all the scans, then at least the anomaly scan you can depute to another radiologist. Then you will have 2 opinions.
Sir, is it possible?
I don't know. Actually, you are all the experts in this field. You can all contribute to this and suggest a practical solution because you are all experienced.
Sir, at our center, we don't have any radiologist actually. We are ultrasound, our basic ultrasound including anomaly and first trimester screening is done by our gynecologists who have been trained as per the law and everything, and we don't recommend all patients to be sent out to do a repeat scan if there is anything doubtful or something extra or something missing?
That's according to your institutional protocol, you can.
Sir, for
We were just discussing how such problems can be prevented, because the focobilia, everything will be a big emotional issue in the courts, and they may award very high compensations in such cases. In the particular case I am discussing, they have awarded 50 lakhs rupees compensation.
One more doubt, sir. Usually what we use, gynecologists did, they'll send the scan for anomaly, but if they miss something, the growth scan will be followed by the gynecologist. So when the litigation comes, they'll litigate only the gynecologist, because they have been seeing the patient several times, but they are not.
Both
So
parties will come. That if only one person is coming under litigation, automatically all related parties will come under litigation. That is usual.
Sir, the another one problem is that these people file the case sometimes even after 3 years, 4 years. That time, most of the hospitals may not have the reports, because most of them discard after 3 years. So everything is EMR. You have to scan the patient's reports. Every ultrasound report, whatever the patient brings,
No,
scan
actually,
it and
as per
store it to
norms,
the
you
EMR.
need not keep cases after 3 years.
3
And
years.
they have to file any civil litigation within 1 year. They can,
But no,
maximum
sir,
of 2 years.
No, even our consumer protection people, they accept the case even after they filed even 7 years.
They can extend the case. That is
7
according
years.
to the particular case, but we can always object. If there is no particular justification for extending the time period, we can always object. Now,
excuse me, sir.
Yeah.
Sir, one more doubt, sir. Sir, if a patient is there whom we have missed an anomaly like this case, will the law be looking at it differently if the scan was done by an ultrasound or by a gynecologist? Who has
No,
taken
at least we
training,
can
or by
say
a
that
radiologist?
due to the, because it is not done by a single person, many people have examined the patient and had a similar finding. So that may be a peculiarity of the some tissues and some justification we can give. Otherwise, we may not be able to justify it very strongly.
Whatever the compensation, if you do done by 2 people, no, whatever the compensation awarded by the court, it can be divided between 2. Why to pay for missing?
That need not be the case in always. Now my next case discussion to Dr. Sajid. 26-year-old primate, normal delivery, no antenatal problems, being treated in a hospital with all the setup for gynecology, obstetrics treatment, etc., but not having very advanced care facilities. Patient had no antenatal problems. Then patient had atonic PPH, tried to manage in the hospital, worsened, referred after 3 hours. Patient had DIC and died in the other hospital. So this is a very common scenario. PPH, DIC, all these things happen very commonly. So what is the ideal line of management, and what all documentations will you do in such cases of PPH immediately and till reference? And what is the ideal time of referral? Because how much blood transfusions you will be doing, what is the time of blood transfusion, what will be the ideal timing of referral, all those things we may have to discuss.
Postpartum hemorrhage, as we all know, we come across in our day-to-day practice, and we should expect any person, any laboring person will develop postpartum hemorrhage at any point of time. So the definition, as we all know, it is more than 500 ml in 24 hours. So when will you interfere with the mild PPH or moderate PPH or severe PPH? That is more than 1500 ml of blood loss. So every unit, whichever labor unit we are working in, should have a protocol to manage the postpartum hemorrhage, because visual estimation of blood loss is not an accurate one, and quantitative measurement of blood loss is the need. So whenever you feel you should not wait for the vital signs to be abnormal because of the cardiovascular physiology, altered cardiovascular physiology in the pregnancy. The changes like tachycardia, all those things will come only later. So when your quantitative estimation of blood loss is abnormal or you are feeling that the patient is bleeding, we should have an insight to start the adequate IV fluids, to have 2 wide-bore cannulas, and as for the necessary investigations, and institute the necessary initial steps of resuscitation. And we should check the availability of our blood, and the preparedness for our unit is very important. Whether we have the availability, if it's not there, we should arrange. Recently, we had one case where the obstetrician was punished for 5 lakh rupees for sending the relatives to get the blood from the blood bank. The verdict from the court was like this, that it was the hospital who is responsible to arrange the blood, not the relatives. And the hospital can arrange blood faster than the relatives. So we should be aware of the readiness of our hospital. What all things are available, what all things could be arranged in that due course. That is very important. And it's I'm not going into the clinical aspect, but if we have a protocol and all of us are working as a team, including the obstetrician, another help, our lab personnel, our blood bank, everything ready, and we are following the proper stage-wise management of PPH. Like stage 0, we just observe and do the initial management, including AMTSL. Stage 2, we ask for blood, and stage 3, we transfuse the blood and blood products, and stage 4, we start our massive transfusion protocol according to the availability of the blood in our setup. If it is not there, we should not wait for the patient to go into DIC. Institute the initial resuscitative measures, and as early as possible, send the patient to a higher center with supports as well as other mechanical methods to stop the bleeding till the patient reaches the higher center, like balloon tamponade or Beckery balloon if you have, or our SR cannula, whatever things we are having. So we should not wait for the deterioration of the patient or patient to get into DIC before referring the patient. That is the most important thing.
And another suggestion from me is that we have a Clinical Establishment Act which has been notified in the state, although our hospitals are not yet registered because it's not fully implemented. But still, minimum standards for hospitals according to Clinical Establishment Act has been published in the Clinical Establishment Council website. So it will have a certain standards prescribed for each type, for maternity home, all those labor cases, standards may be prescribed. You should refer to that standards and ensure that all the standards have been met in your institution. Because nowadays, if some maternal death or something happens in an institution, as a part of audit, whether this institution had all these standards met also will be checked. So that's also an important area you should look after in future.
One more point is that when you are referring a case like this, you have to inform the higher center that we are referring this type of case. Otherwise, they will also not be prepared to attend this.
Now, the next case discussion with Dr. Ram Gopal Pillai. The situation is that a 27-year-old lady, she has underwent artificial insemination donor in an institution. And subsequently, there was commotion and complaint in the hospital that they were not informed that the insemination was from donor. They were expecting insemination from husband. And that was a lot of issue was there, and even a case was filed in the civil court regarding that incident. So what is the ideal situation? What is the type of consent you use? How do you counsel? What all things will you do? How can you prevent such situations?
Thank you so much for the question, sir. Sir, coming to all patients needing artificial insemination, we should be, first of all, from the history and documentation of the investigations, we should come to the conclusion that we will be planning for husband insemination or donor insemination from outside. So already we would have counseled the patient, should have notified in the case sheet and documented that.
Counsel means, is that counseling recorded or counseling? Because usually we say that we have counsel. But is there any recording of counseling or any documentation that you have counsel? What is
Sir,
that
we will counsel
protocol?
We will counsel saying that these investigations and findings have been explained.
What
to
is the
patient.
evidence of that counseling? When a similar case comes, what is the evidence of that
It will be
counseling?
documented in the case sheet as well as in the form of a different consent, and we have a special counselor for all the fertility couples who are taking treatment also. So separate consent will be there. In the documentation page also it will be there, and it will be separately documented by a counselor also, PhD counselor. 3 things we will be noting down with the thing that the options given are husband insemination or donor insemination, or if we are trying for a procedure in which we are planning to get the husband semen, if it is successfully got, we will use husbands, or if it is a failure, then we can opt for the. So all the previous options will be explained to the patients, along with the consent will be taken earlier itself. Then to prevent any mix-up of these cases, all patients should have that unique identification number, which should be noted on the semen collection cup, or as well as in all the investigation containers, and it should be double witnessing or double. 2 people should at least see the patient, the sample, as well as the documentation, what the patient is confirmed the treatment, is it for husband insemination or for donor insemination. And in some of the cases, what happens is that the husband might come and say that, sir, my sample might not be of that good quality. So if it is not of that quality, you can use donor sample. But then you have to get the consent correctly, because after some time the husband might change his word, or the wife might not be knowing about it. So you have to take the consent of both the parties of the couple, so that in the future you will be safe against these litigations.
Now there is an Artificial Reproductive Techniques Act is in place. So what all changes have come after this Act is in place? Act in place. What all changes? What all additional things?
Sir, mainly 2 things have come. That earlier all centers, all gynecologists can be doing IUA. But now to do the basic IUA, you have to get your center registered as an ART level 1 center for doing IUA. And all IVF centers should be registered as ART level 2 centers. And for doing surrogacy, you should get a surrogacy registration as well as. This is the major thing which has come into force.
Thank you.
For urology and related and sperm retrieval techniques, earlier many gynecologists could do the same procedure, but now we have to use the service of a urologist when we are performing such procedures.
Urologist or surgeon's help. Like there's a specific qualification has been mentioned. Only thing is that as per the ART Act, we have to take an informed consent. We have to, any procedure they are doing, we have to first counsel the patient, document the counseling, and make sure they write their own handwriting, that all the procedures has been explained to them, and we have to explain them chances of what is the success rate, the cost of the procedure, the chances of ectopic, missed abortion, all the possible complications, or if you do IUI, she will not become pregnant, all that, everything, all things we have to do in the counseling only. There are the gazetted, government gazetted consent forms are there. We have to follow that consent form. We have to do the counseling. Any treatment cycle, only one procedure has to. We cannot mix up husband's gamete with or donor gamete. One cycle, if you plan for husband gamete, finish off the cycle with husband gamete. If it fails, we can think of donor gamete. In this, actually, the scenario we were discussing in the pre-lunch session, we 8 male guys were discussing the clinical cases which had come in our practice. This one only. Ram Gopal was not there. So we all face a problem. Many patients conceive with their partner, means not with the husband. Then they come back and they say, one doctor said that the patient came and demanded, give me a certificate stating that you had done IUI in me, because the patient conceived 3 weeks before the husband comes. They will leave. Then another one patient, husband, everybody, almost, we are 8 gynec males were there, all the 8 infertility practicing people, they all have same experience that testicular failure, husband's wife conceiving naturally. So, so many things we can see in the clinical scenario. Even even at all we do IUI with the proper documentation with the IUI husband's sperm, the patient can go and get concealed from some other person. So that scenario, it's difficult. How we will justify that? That's a problem.
Okay. Now we'll have a discussion by Dr. Simi. The situation is that 40-year-old lady underwent hysterectomy. After 5 years, she took a USG for abdominal pain. In report, ovaries are not visualized. She has given a complaint that the ovaries were removed without her consent, and hence she had a lot of symptoms like hair loss, back pain, etc. due to loss of ovaries. So, how are you, what all documentations will defend you in court, and how are you going to defend such a case?
First of all, the indication for hysterectomy. What is the indication for hysterectomy at 40 years of age? So in that case, if there is an ovarian problem, we'll definitely take a consent. And otherwise, if it is some fibroid or something, we usually keep the ovaries. And even after 45 years, if you want to take the ovaries, you should definitely take a consent. And that consent also, as I already have said, we should make them read. Because most of the time the patient says that we have not read the complaint, it was just written, it was a formally written consent from the hospital. So we have to make sure that they have read the consent and then only sign. Then after the surgery, sometimes we will feel like, okay, we'll remove the ovary because it seems to be diseased. So in that case, we'll usually tell the bystanders, but most of the time the patient will be under anesthesia. We may sometimes, there's chance that we can forget. So make sure that we'll explain to the patient after the surgery that we have taken your ovary or one single ovary or something. And when the histopathology report comes also, we can make sure, see your uterus is, only your uterus is being taken out.
So one of the defense will be histopathology report. If there is no ovariotomy, then ovaries will not be there in the histopathology report.
Then next. After, you see, this patient has, I think, completed after 5 years, right, sir? So that ovaries might have shrunken. That could also be a possibility, and see, after surgery, there can be misplacement of the ovarian site. Like after you do the hysterectomy and then you do the scan, after 5 years, ovaries. So
another difference is that ovaries will be shrunken and placed in different positions after hysterectomy. So then her symptoms can be also due to menopause, all these symptoms.
So regarding the consent, whether the pre-prepared consent is valid in the court of law, or we should prepare, or we should make the patient write a new consent and sign on it.
Actually, this case was there, but these were the same defenses which were placed in the court by our team, and the court set aside the case and did not allow any compensation for that case. Now we go to discussion by Dr. Sajid. A lady with gestational diabetes underwent normal delivery. Then patient had shoulder dystocia. Baby had left brachial plexus palsy. Birth weight was 3.7. Allegation of not performing cesarean at the appropriate time. So this is a particular situation, because if you do cesarean in some cases, they will allege that unnecessary cesarean has been done, and if there is any complication, then there will be allegation that cesarean was not in appropriate time. Another allegation in such cases of gestational diabetes will be that always cesarean should have been done because you macrosomia and complications in vaginal delivery are you always expected. So what is your take in that case?
So there are a few things about shoulder dystocia. When we talk about shoulder dystocia, it can come to any patient. So any lady can develop shoulder dystocia, and there are some high-risk patients whom we should anticipate shoulder dystocia, and we should have our preparedness, or we have done our pre-drill sessions and all those things. If you have done or you have demonstrated your adequate skills in delivering that patient, some damages to the baby can happen, which we should counsel the patient before going in for the procedure. The thing is, when will you call a shoulder as shoulder dystocia? Okay, so if a shoulder is not coming out after 60 seconds of the delivery of the head, and immediately it's again a teamwork, we should form our team and we should try to deliver using different maneuvers. And even after demonstrating that much skill with your team effort, if something goes wrong, I think we can defend that in the court of law. Whether to do a C-section at that point of time is debatable, because even 4 or 4.5 kg baby can be delivered without any problems. Even a 2.5 or 2.7 kg baby can have a shoulder dystocia. So that depends, and we cannot offer C-section for all the patients.
So we can go in for pure technical defenses in such situations with ample scientific evidences. Now we go to another case discussion by Dr. Biju Pillai. Lady aged 19 years in the hospital records underwent MTP. Subsequently, there was a POXO case related to that, and actual age of the patient was less than 17 years. And gynecologist was implicated in POXO case for non-reporting. So this has occurred in many areas, because people come and report that they are 19, 20, etc., and get admitted and undergo MTP. And subsequently, police comes and say that they have not reported a case. It was a case of some child abuse or something. So what is the ideal situation? What all precautions you should take in such cases of MTP when you are conducting MTP in suspected cases?
MTP, any patient, any lady approaches us to MTP, we cannot deny it. We have to do it. The second thing is, there are in Kerala, there is a circular when Dr. Rajiv Sadanandan sir was the health secretary. He had sent a circular with a type format that if you feel the patient is underaged, get a declaration from the patient and bystander. It's a government, it was a government order, maybe 7 years back it came. Clearly it's written the patient's age is so and so, the patient signs, then the bystander certifies it in the below it. That is already is there in Kerala. We have to follow it. Any patient, even that he's clearly mentioned in that any antenatal case, not only MDP, any antenatal case, we have to take this consent. Second thing is, the most of the time, every hospital now, the reception or will have a form where the patient or bystander itself declares that their age. That also we can form. Then second thing is, in this case, doing underage below 18 years MDP, it's a legal thing, but not informing the patient, the police is the issue here, because it falls under rape. So in that case, only thing we can is self-declaration from the patient and patient's own bystander. And ID card, I don't know how far it's practical, because as long as it's... And secondly, you have to take any MDP, you have to take a consent form C. Recently, one of the gynecologists got arrested for the same thing in Kerala only, POXO case. So this is the reason. The reason was this one only, the patient didn't inform the police. But we should understand, any MDP, we don't have to, usually everybody for MDP, we take a consent in like our surgery consent. But there is a government notified Form C consent. We have to follow the Form C consent. Even in the case of minor, we have to take a consent from the patient's bystander. Then the amended MDP Act, we can do up to, I think it's 20 weeks one gynecologist, more than 20 weeks two gynecologists, because it was 12 weeks.
No, after
2024, gynecologists.
And after that, you have to get sanction from court only.
No, after 24, you have to get the sanction from the court.
Not from the court. According to the new MTP Act, it is State Medical Board. State Medical Board is formed at all the medical colleges as well as the district hospitals. So you can send.
They have to file a petition in court, and that they will refer it to medical board. No.
The treating gynecologist should refer to the State Medical Board.
Okay.
Sir, one more question. Sir?
Madam, this Aadhaar card is not a legal document. You should understand that. Ah.
But for
See,
benefit
madam,
from all government schemes, Aadhaar card is mandatory.
yeah, Aadhaar card, the issue is that in ART Act, it's clearly written we have to do a IVF for a married couple or unmarried female. Some patients in the verge of divorce or they get married unofficially and they come for treatment. If I tell them bring Aadhaar card because or marriage certificate, these people what they will anyone can change the address in Aadhaar card.
But my suggestion is that in MTPs, one thing is that hospitals do registration by two methods. One, some patient and bystander will come to the reception, they will tell their name, age and address, and people will record it in the case sheet and admit them. In some hospitals, there will be a form that will be filled and signed by the patient and bystander. Always insist on a form filled by the patient and bystander so that we can just at least prove that the patient himself or herself had declared their age by themselves and it was not manipulated by us. Second thing is any form of identity card can be verified for MTP cases. That will be better because there can be such medical legal issues. Yeah.
We have to have another supporting evidence to say, because these people will change their, statement.
Yeah.
So always have something additional to certify the age, especially for the box of act.
And regarding MTP also, that there are certain legal compliances. As he told, there is a specific consent form, and also outside the case sheet, the patient's name should not be written, and the case sheet should be separately kept in a particular locked cupboard. All those regulations regarding MTP case sheet maintenance is there.
That is there only in the union territory, sir. That
No. It's applicable in state.
There are few forms to be filled for all the MTPs. Form C is mandatory, which should be filled by the patient alone. And as per the court directive, we need only the consent from the female. No one else should sign any of the consent, and we are not supposed to ask for any consent. And there should be a mandatory MTP register, which should be kept in the safe custody of the physician who is doing it. And that register should not have any identification of the patient. That is very important.
and no one. No, sir. That is notified only in the union territory.
No. It is
not
applicable all over India. It is applicable.
It's clearly explained.
No. It is all there in the MTP Act. It should be compulsorily followed in all centers doing MTP.
Sir, one more question. Sir, now a lot of living together people are coming for MTPs. So do we have the right to deny that we can't do that?
Deny?
Some person are...
Actually, any private practitioner can choose his case. They can say that I cannot do this because they are free to choose the case. But in government hospitals, they cannot deny the case. There should be some particular reason.
We cannot we cannot deny MDP, sir. When the lady approaches for MDP, we are not supposed to deny it.
If your sender is registered for MTP, we cannot. If your sender is registered for MTP under MTP
the point
Act,
which I missed is that if you are doing MDP, make sure your sender is registered. If you are doing medical abortion, the hospital where you are attached, you should have an attachment with the hospital where it's been registered with the district medical officer, medical MTP. Many people, we don't know that act, because the file a case means that will stay in the court.
No, the thing is that this is technically correct because MTP can be done in only centers which are registered for MTP. But there can be a lot of sender-specific issues because if the gynecologist is not there or she cannot take such cases in OT, in such situations they can refer the patient. They can refer the patient. There is no issue. It is not mandatory that you should do MTP. You can always refer them to another center. Now we go to another case for discussion. This is regarding one patient had undergone MTP by D&C. And after that, pregnancy was continued, and she delivered subsequently. It was identified after 20 weeks, and she had to continue pregnancy and delivered. So there was a complaint was the MTP or DNC was not done properly, and the products were not properly examined. There was no histopathology examination done on the products of consumption which is removed by DNC. So what is the defense? What is the situation? Is histopathology always mandatory in such cases? How do you confirm that MTP is complete?
So regarding this case, sir, once you are doing a DNC for a patient who has come for termination of a pregnancy, first after the procedure itself, we will be doing a check ultrasound to confirm that most of the products have come out or the cavity is empty. And that will be documented as an ultrasound report along with the procedure notes. And secondly, in most of the cases, we will be sending the products for histopathological examination also. In any case where the patients are asking, or in those cases where there might be chances of a future problem, we will be sending the histopathology, but not recommended for all patients. So that is what we follow.
So only ultrasound.
Ultrasound and histopathology in selected cases, sir.
Selected cases
Selected
only.
cases,
Rest
not
of the
for all.
cases, what is your documentation? Are you physically verifying the consumption? What is that? What is your documentation regarding that? How do you ensure that the MTP is complete? Yeah.
The concern you will be getting in writing saying that I will come for follow-up after 2 weeks and for the next 3 weeks. So that consent has to be there. Suppose we didn't turn out after 2 weeks or the period is missed, the fault is not on the doctor because always it need not be come.
And what will you do after 2 weeks?
We will see the scans of ultrasound.
So that is what I am asking. Is a follow-up scan after 2 weeks is mandatory? That is what I was asking. So this such type of case can also come. So we have just discussed these few cases just to have an awareness on the types of litigations you may face in gynecological practice. If you have any cases to be discussed from the audience, you can also stand up and enumerate that problem so that we will discuss. Otherwise, if you have any questions, you can ask those questions, or we will end the session soon.
So regarding this case only, sir, are follow-up scans mandatory in a court of law to prove that we haven't missed?
That I cannot say because I am not from your specialty. That this forum should tell.
Sir, is histopathology also needed? Both are not needed, no?
Yeah. Three years. 3 years, always the storage of case sheet will be for 3 years. There is a question from audience. Have you ever come across any case regarding wrong embryo transferred to wrong patient? In our professional protection scheme, such a case has not yet come because there are minimum number of cases regarding artificial reproduction techniques in Kerala. So many of the cases may be related to this intrauterine insemination and all. Regarding embryo transfer, failure in conception after prolonged treatment may give rise to some form of litigation. The techniques are not correct or patient had pain. Such trivial cases only have come. This type of case have not come yet. Is there any particular instance? Should we discuss it?
Sir, we have a interesting case in one of the couples. They were not able to provide the semen sample in the hospital itself. So as a next step, they were allowed to produce a sample from home and bring it. So after the conception and pregnancy, after a few years, there was a complaint from the patient side that that sample was not from her husband's. It was her partner's or somebody else's sample. But because we usually take a separate consent stating that the sample was brought from outside and they also sign on it, it didn't become a big legal problem. So always get a sign when they are doing something extra and when the sample is not being collected in your
Can they
hospital,
bring sample from outside? Is it allowed?
if in the hospital, if they are not able to collect in near the laboratory in the hospital, then they have to get it collected.
So
from
is there
outside. They
any
have to buy.
particular minimum standards required for this collecting centers for artificial insemination?
So we'll get a consent extra and tell them to keep the sample near to body temperature as possible.
Okay, thank you. So if you don't have any other doubts or discussions, we will end up the session. Thank you very much. Thank you all the panelists who have attended, Dr. Biju, Dr. Ram Gopal, Dr. Simi Harris and Dr. Said Mohan.